that's why. 205 was a parking lot, and it was, there must have been 30
So,
you could see the cars and people.
I'm not sure where she went.
Yeah. Where were we at that point?
Were you going to use that?
Yeah, I think. Turn it on. Hello, hello, hello.
Sounds like it works.
Yeah, it works.
I'll just put it on.
Good morning. I think we best get started. I'd like to remind you briefly who Huldrych Kammer was. How many of you knew Huldrych? Can I see a show of hands? Every year there are fewer hands. So this is the 15th year of the annual Huldrych Kammer Memorial Lectureship. You can't hear me? Okay. Borrow the mic. This is the 15th year now? Oh my. Hello, hello.
He just sat down back there and he's waving, so let's see.
Okay. Welcome. Hello. Louder. I'm hearing there we go. Hallelujah. Welcome to the 15th annual Huldrych Kammer Memorial Lectureship. Dr. Kammer was the first academic endocrinologist in the state of Oregon, the first member of the faculty in endocrinology at the Oregon Health Science University, had a career that spanned some 50 plus years as a leading teacher as well as provider of endocrinologic services for multiple hospitals, including the university, and then for 35 years we enjoyed his talents here at Providence Portland Medical Center. Won many teaching awards to acknowledge his expertise, the Laureate Award of the Oregon chapter of the American College of Physicians as one example. There's an award in his name given at the university in the Division of Endocrinology on an annual basis. And his passion, not only for the highest possible standards in delivery of healthcare, was that we stay in touch with the cutting edge of developments in endocrinology. And it was his wish that there be an annual lectureship to ensure that that happened. And hence the memorial lectureship that we're going to enjoy this morning. I'm going to ask Elizabeth Stevens to introduce this year's lecturer. Elizabeth?
Pass the mic.
Yep.
Is the overhead mic working now? No. Is back? No. All right, I'll use it. Good morning, everybody. Welcome to the Kammer Lectureship. It's really an honor for me to be back to do this introduction because every year we get such amazing speakers who are generous and love to teach, and I think really it's been a delight to be a part of this program, and I really thank the foundation and the Kammer family for continuing to support this because it's really been a wonderful opportunity for our residents and faculty and for myself personally, so thank you. This year is no exception. We have a wonderful speaker. Dr. Dan Bessesen is a professor of medicine at the University of Colorado School of Medicine. He is chief of endocrinology at Denver Health and the fellowship program director for the fellowship training program in endocrinology. I did my training there, so I've known Dan for many years. He is also interim director of the Anschutz Health and Wellness Center. Dan got his MD from the University of Colorado and completed his residency and chief residency there. He also did his fellowship there. He's conducted research in dietary fat metabolism, body weight regulation, and the clinical problem of obesity for many years. He is involved in a lot of program development and writing in regards to obesity and has received a lot of teaching awards and accolades for his teaching, and I can also attest to that. It was really a wonderful experience to learn from him when I was in Colorado for 3 years. Today he's going to be sharing on how losing weight, why is it so hard, and what we can do to help.
Just such a pleasure for me to be here. I've had such a great couple of days here. The weather's like this all the time here. Is that right? That's what Liz keeps telling me. I'd almost move here with that. I want to thank the foundation and the Camera family for having me. I got to spend some time with them last night, and that's terrific. You know, thinking about Dr. Camera, I think for all of us, it's a moment to reflect on what's valuable in the work that we do, especially the rewards of teaching and patient care. I think those of you who work with residents and fellows, I must say from my perspective, it's more rewarding for me than probably for them. And it's such a privilege to be able to work with young people as they develop their own professional identity. So thanks for letting me come here. I really appreciate it. Liz asked me to talk some about weight, and so we're going to talk about losing weight. Why is it so hard, and what can we do to help people here? Let's just start with a patient here. MG is a 48-year-old woman who has type 2 diabetes. She's on metformin and glipizide and has an A1C at 8.5. She has peripheral neuropathy, and she's on gabapentin for that, and she also has depression, for which she takes paroxetine. She's 5'5" and had a peak lifetime weight of 228 pounds, which gave her a body mass index of almost 38. She went on a low-carbohydrate diet at the recommendation of her friends, and she lost down to 185 pounds. And even though that wasn't where she wanted to be, she was happier there. But unfortunately, over the subsequent months, she's gradually regained to 198 pounds. And that number 200, she just doesn't want to go over that number. And so her BMI now is about 33. But she's frustrated, and she comes in asking, what can I do about this problem? She's trying really hard, but not having the success she wants. So what we're going to talk about is this issue of why is she regaining this weight? Why is she trying so hard and yet not having the success that she's looking for? And then in the context of these medical problems, what can we talk about in the brief time we have in the office? It's one of the challenges is you don't have a lot of time to talk about this stuff, so how can you efficiently review some of the options with her? Well, this is a meta-analysis of many types of diet studies. This is how much weight people lose over a period of a couple of years with exercise, diets, meal replacements, medications. And the pattern's clear. People can lose weight over the short term. That doesn't seem to be the hard part. The hard part seems to be maintaining it, that once people lose weight, they just gradually regain weight. So what's that about, and how do we deal with that? Well, this is a super old animal data. These are rats. That's how much a rat weighs over its life. A rat's life is shorter than a human life. But what you can see is that a rat living in a typical rat life gradually gains weight over time. And yet, if you take a rat at some point in its life and you overfeed, and you overfeed it, you can have the rat gain weight. So you put a tube in the rat's stomach and it gains weight. But then if you stop that, you stop overfeeding the rat, what does the body do? And the rat's body gradually returns not to the weight that it was at, but to the weight that it would have been at had nothing happened. That's just crazy. And how about weight loss? You can take a rat and put it on a diet and it'll lose weight. The rat doesn't care that it's on a diet. It's regulating weight physiologically. And when you stop the diet, what does the rat do? The rat's weight returns, again, not to where it was, but to where it would have been. So to me, as an endocrinologist, this is a regulated system. The body regulates weight, but it's not a set point. It's not a fixed number. It's a trajectory. It's a developmental trajectory, really. I mean, we think about developmental processes as a thing that change over time. The term for this, actually, it's not a homeostasis. The term is homeoresis. It's regulation around a trajectory. And I think that's important because I think when we see our patients, that seems to be what happens. Now, not everybody's the same. There are people, because of their genetics or the environment that they live in, that their trajectory seems to be higher. I mean, why is there so much problems with overweight and obesity these days? It's many factors, but many of them are environmental. So if you take a rat and put it in a cage with high-fat food and no running wheel, it's going to gain more than if it's living on a lower-fat diet and has access to exercise. There are genetic strains of rats and probably humans that are more resistant to gaining weight. In fact, constitutive thinness, people who don't seem to gain weight, that's a strongly genetic trait in the current environment. So it's not like there's one trajectory that each person is destined to follow. There are genetic and environmental factors involved. But there is a trajectory for all of us. Most of us tend to gain about a pound per year through our whole life. Well, that's rats, but what does this have to do with humans? And one thing I do in clinic is I ask people to just draw out their weight. Show me what your weight has done over the last 20 years. And most people's story looks something like this. I went to college and I gained some weight in the dorm, and then I maybe got married and lost some weight at the time of the wedding, but I got pregnant and gained weight and I just couldn't lose it. I went to Weight Watchers and had some success, but then I gained the weight back and then some. I had a stressful job. My husband's a bum. And then I went on a medication, lost some weight. So when I look at this, this is a frustrating story for people. A person might look at this experience with Weight Watchers and they said, yeah, I lost some weight, but then I gained it back and then some, is the typical thing that the person says. And I draw this picture for people and I say, this seems to be our understanding of the biology, is that there is a developmental trajectory that your body tends to follow. And you can fight it, you can put yourself on a diet, but the body's going to push back here because this is a regulated system, and it's going to return to where your weight would have been. And so I'll ask people, I'll say, well, how much would you weigh if you weren't doing the things you're doing? I have people who say, guys, I'm exercising, I'm restricting my calories, and I'm so frustrated. I say, what do you think your weight would be if you weren't doing those things? I asked this to a guy a couple weeks ago, and he kind of looked at me incredulously, and he said, sky's the limit, I think. So he's aware of this physiology. People are aware of this physiology in their own bodies. Nobody chooses to gain weight and be quite heavy. They're experiencing their biology in the context of this environment. So that's the challenge they have and we have. Well, why is it so hard for people to reduce their weight and keep it down? Isn't this just their choice? Can't they just stick to that diet and just exercise more? Well, I think the answer is that's more difficult than it would seem, because weight is regulated in a manner that, first, when somebody loses weight, their energy expenditure declines. Why does that matter? Total energy expenditure equals how many calories you get to eat every day. So if your energy expenditure goes down, you don't get to eat as much to maintain that weight, and that goes on forever. Metabolism changes in a manner that promotes weight regain. People's insulin sensitivity improves. That's good for their metabolic health, but insulin sensitivity means you store fat and it makes it difficult to lose weight. Appetite changes. When somebody loses weight, the brain says, this isn't right, something's going wrong here, and people are more hungry and food has greater salience, meaning food in the environment is just more attractive to people, and I'll show you some data about that. Now, these forces can be counteracted with diet, exercise, medications, and surgery, and we'll talk in the second half of this about some things we can talk to patients about. But the sheer willpower of diet and exercise is challenging for people because they're pushing back against these physiologic mechanisms that are trying to cause their body to regain weight. Well, let's talk about a couple of these things. First, energy expenditure. Energy expenditure, I'll show you some data on this. Energy expenditure is linearly related to lean body mass with a non-zero intercept. What does that mean? I'll show you a picture of that. But basically, the bigger you are, the more you have to eat, or the more you do eat because your energy expenditure is higher. But when somebody loses weight, their total energy expenditure declines out of proportion to their loss in lean body mass. So the body becomes more efficient. The physiologic mechanisms are such that the body says, there's no food here, I need to burn fewer calories. And there's a lot of biology about the mechanisms for that. This decrease in energy expenditure is in part due to changes in basal metabolic rate. That's just the energy cost of just sitting there doing nothing, but also energy expended in physical activity. If somebody weighs 300 pounds and they walk a mile, and now they weigh 200 pounds and walk a mile, there's less energy expenditure because they weigh less. But in addition to that, their muscles are actually more efficient. So for the same workload, they burn less calories when they lose weight. Here's the relationship between energy expenditure, 24-hour energy expenditure measured with a sophisticated method, and fat-free mass. So a bigger person has more fat-free mass. That's why, because if you're bigger, you're carrying more weight, and so your muscles are bigger as well. Your heart's bigger, your kidney's bigger. And so people who are larger people are up here, thinner people are here. And what you can see is how many calories you get to eat every day, because that's what 24-hour energy expenditure equals when you're in weight balance, is how many calories you eat. And what you can see is people who are heavier eat more calories. Somebody who has 100 kilograms of lean body mass is eating 3,000 calories a day. I mean, there's some variability around this line of identity. Some people are more efficient, some people are less efficient energetically, but in general, energy expenditures related to your body size. This is an interesting study, though. This is an old study done by Rudy Leibel. Took a group of people, and some of them, it's just kind of that rat experiment. He overfed people so they gained 10% of weight above their initial weight, or they lost weight, and then this group lost as much as 20% of their body weight. So he looked at what happened to energy expenditure when people gain or lose weight. So on the top here, we're looking at total energy expenditure of each of these peoples. The open squares are them at baseline, and the closed squares are after they've been overfed such they gain 10% of their weight. And what you can see is that people are on the line, but then when they gain weight, they're more energy inefficiency. For the same body mass, they're burning more calories. So this is a homeostatic system. You overfeed, you increase your energy expenditure as though the body wants to get back where it was before. Conversely, when people lose weight, here the open squares are them at baseline, and the closed figures are following a 10 or 20% weight loss. And so what you can see is people are more energy efficient. Same weight, lower calories, and it's several hundred calories. This is what's so frustrating. People are sitting there at the table and they're looking at the person next to them, their husband or something, and says, "Why do you get to eat that? I don't get to eat that. If I ate that, I would gain weight." And some of the answer is that they're more energy efficient as they lose weight. And this is both due to resting energy expenditure, but also non-resting energy expenditure, the energy expended in physical activity. Well, maybe this just goes away after a while. Maybe the body just gets used to this. Here's data on, let's just look here on total energy expenditure. This is energy expended at baseline, and then people lose weight. Their energy expenditure goes down by about 300 calories, and a year later, it's the same. It doesn't go away. It's not like the body got used to that. This is a persistent issue, and so for that person to maintain a reduced weight, they're going to have to reduce their calories forever. Well, that's hard, isn't it? But that's the reality. That's just the reality of what they're going to have to do. Well, this is a little bit of distinction from the person who's gaining weight and who comes in and says, "I'm eating nothing and I'm gaining weight. How can that possibly be?" And I encounter this a lot. We get asked, people feel like they have a metabolic problem. This is a study where they took folks like that and they put them in a metabolic chamber and they said, "Mrs. Jones, we're going to figure this one out. We're going to measure how much energy your body expends. We're going to weigh and measure your food. We're going to see how many calories you're going to eat. We're going to work this math out." And here's what they found. The open circles are a control group. The closed circles are people who said, "I'm not eating anything and I'm gaining weight." And what you can see is they're all on the same line. And here's their food intake energy expenditure data. Each of these is an individual person. Let's just take this particular person. And they measure his energy expenditure, and it's 2,500 calories a day. So that means to maintain that weight, he's got to eat 2,500 calories a day on average. So he's in the center, and they're weighing and measuring how many calories he's eating, and that's this next bar. He's eating 2,800 calories, being observed to eat that. But when they ask him to report his diet, he says, "I'm eating 800 calories." So again, you might, and again, it's a natural reaction to say, "What's with that guy?" But to me, what this shows is how difficult it is to know how much we're eating. I actually think this is the problem, is people who struggle with their weight, their brain doesn't exactly know what they're eating. It's very difficult. I don't know how many of you have ever tried to monitor your diet. First thing is it gets boring after a while to log every single thing you eat all day long from the time you wake up. I mean, if there's food there, it goes in my mouth. And so it's hard to know what you're eating. I think what this person is saying, when this person says, "I'm eating nothing and I'm gaining weight," what they're saying is, I am trying really hard here. I'm using a lot of cognitive effort to resist food that's in the environment, and this self-reported caloric intake, what it reflects is the challenges the person has. So I don't share this data with patients who ask me this question. It's usually not a helpful direction to go because the person has only a couple of choices. They can eat less, and usually they say, "I don't think I can eat less. I'm eating as little as I possibly can." They can exercise more. They could do something like medications or surgery. I wish I had better treatments, but that's all I got. Well, why are they more hungry when they lose weight? This is a study that looked at the effect of weight loss on hunger hormones. So this is a group of people who weighed 95 kilograms, and over a 10-week period, they lost about 10% of their weight, and then over a year, they gradually regained weight. Same story that we usually see. But what they looked at is what happens to their hunger after they've lost weight. So this is wake up and say, how hungry are you? I'm 30 units hungry. The higher the number, the more hungry. It's this visual analog score. And now you eat breakfast and the hunger goes down 30 minutes later, and then by noontime I'm hungry again. So this is just self-reported hunger. And what happens is when somebody loses weight, their hunger goes up. It's a modest effect, but this is self-reported hunger. I am more hungry. And then a year later, they are still more hungry. So energy expenditure goes down, hunger goes up. Why does hunger go up? Well, these hormones change. Ghrelin is a hormone made by the stomach and small intestine. Here it is in that meal challenge at baseline, and here it is 10 weeks and a year later. Hunger hormones go up after weight loss, and satiety hormones like amylin, PYY, CCK go down. So again, this is a regulated system, and it regulates in such a way that energy expenditure goes down, hunger goes up, and so people tend to regain weight. It's the body just doing, we regulate serum sodium, we regulate our PO2, and we regulate our weight. Well, how does this work? How does food intake work in the brain? There's been lots of work in the hypothalamus, and we know a lot of the neurophysiology and neuropharmacology of weight regulation in the hypothalamus. That's all about hunger. But why do we eat? I must say, I was out there this morning and there were donuts in there, right? And then that donut, it's just like my eyes go to the donut. It's like, I'm having one of those things, right? So, and why is that? Is that because I'm hungry? No, it probably has to do with reward. Well, what is reward? We've learned a lot about the neurophysiology of reward from drug addiction. And in people who are addicted to drugs initially find it rewarding, and so it becomes repetitive behavior. But these pathways in the brain that are involved in making things rewarding probably didn't evolve for cocaine. They evolved for common things like a donut. And so we now know the neural substrates. It's the ventral striatum is an important brain region. Dopamine is an important neurotransmitter in that region that integrates the rewarding qualities of food and other things. And in fact, there's probably variations in the basic biology of reward that are involved with why some people gain weight and some people don't, as well as why some people are more prone to addiction and others are less prone. There's this interesting idea that came from addiction research about liking versus wanting, that initially people who are addicted to drugs, they find the drug rewarding, they like it. But then after a while, they don't actually like it anymore. It's just if they can't have it, they feel bad. And they have a craving or some wanting. People ask me, do people get addicted to foods, like addicted to chocolate? I must say, I think it's not a great analogy, because if a person doesn't get chocolate, they don't have withdrawal symptoms in the same way you do with drug addiction. But I think this idea that there are people who at a certain point say, I really don't want to be eating this food, but I feel a craving or a need to eat it. So I think there's more to be learned from addiction research, the neurophysiology of reward, that may relate to food intake. We've done some work in this area. Some years ago, we started to do functional brain imaging, where you can sort of see what brain regions are doing in response to certain stimuli. And when we did this, not a lot of people had been doing this, and we said, well, let's show people pictures of food. And we looked at some pictures of food like this, and they said, oh, yeah, that's food. And then you look at that picture, and you go, oh, yeah, but that's really food, right? If you haven't had anything to eat, and you see this picture, this is a really, compared to that, I show you this picture, your brain goes, I wonder what that book is. You're trying to make sense out of this thing. But you see this, and the whole body goes, I know what to do with that. And so we call these highly palatable or hedonic foods. So we divided our food stimuli pictures into these more utilitarian type foods versus these high hedonic foods. Now, different people find different foods hedonic, and we had them rate this sort of thing. But so then we would show them these pictures and see what the brain does. And we would do this in people who were fasted and on a regular diet, so they're kind of hungry, or we do it after 3 days of overfeeding them, the kind of post-Thanksgiving sort of thing. So how does your brain respond to food in the environment when you're either fasted or when you're overfed? Well, if you take a fasted, thin person and show them those pictures, the brain lights up like a Christmas tree. The ventral striatum, that's the rewarding part of the brain, says, oh, I know what to do with that. The insula, this signals kind of neurochemical and physiologic stimuli. The visual cortex, this is a potent, and again, this is subtracting the controls from the food. Just your eyes go to a rewarding stimulus like that powerfully when you're hungry. Now you take these same folks and you overfeed them for 3 days, and nothing. All that stuff goes away. So there's something about the actual rewarding or salient qualities of the stimuli that is regulated by energy balance in a way that you would think in any regulated system. So these thin individuals, they respond to the stimuli in a way that helps them maintain body weight. How about people who've lost weight? Take those folks and show them pictures of palatable food, lights up like a Christmas tree, overfeed them for 3 days, and what happens? Still lights up like a Christmas tree. So it is as though the energy balance information that should be regulating the system is not working. So I bring this up in that, again, I think I showed you that prior study where the person said, I'm not eating anything, I'm gaining weight. I think what they're saying is the food still has this salient information. I have to resist this with cognitive effort. So I think there's fundamental biologic differences. Some of us struggle with our weight and some of us don't. I think those of you who don't struggle with your weight, I think don't necessarily really understand what the experience of food is for other people. And it's relevant because we talk to these folks. So I hold this picture in my head where I talk to people who struggle with their weight. Well, maybe the body just gets used to this. Just do it, lose the weight long enough, and maybe all this stuff is going to go away. This is a study that Paul MacLean did. It's a rat study again, because you can control everything in a rat's life. So the rat's gaining weight, and then Paul puts them on a diet. And they lose weight, and then he keeps their weight stable for a long period of time. This is a younger rat. This is getting to be an old rat. And the question is, if the weight is down for a long period of time, does the body then reset the set point, and now they defend this weight? What do you think is going to happen? Weight goes back, you stop the diet, and the weight goes back not to where it was, but to where it would have been. That's the biology. So the longer the period of caloric restriction, the faster and higher the regain, because the farther the physiology is from where it's supposed to be through this developmental weight gain program. So as near as we can tell, this stuff doesn't change with time. This is a developmental program given a particular environment. Again, if you totally change the environment, and we went from living in Portland here to having to be an agrarian farmer in northern Mexico in the summer, yeah, your weight's probably going to change because the environment is dramatically different. But if you're the same person in the same place and the chips are in the cupboard before and they're still there, probably the weight's going to go where it would have otherwise been. Well, let's go back. That's depressing. I'm sorry. But I think it's reality. It's the reality that our patients deal with, and it's the reality of our therapeutics. So let's go back to this person and think about this. We got 15 minutes. Oh, I don't know. Epic, maybe we have even less than that. Did I say that? So what are we going to do? The person has type 2 diabetes, so has a health problem related to their weight. Their glucose control isn't great. They're on glipizide. What does that do to weight? They're on gabapentin and they're on paroxetine. So one question we have in the clinic is, are we doing something that's promoting weight gain, and should we do something about that today? Her BMI was 38, and though you already know that the kinds of treatments we offer patients are based on their weight. People who are heavier, we tend to offer them more aggressive treatments. This puts her in a category where surgery might be an option for her. But she lost weight, and now her BMI is 32. So how do we think about the treatment options she's eligible for? Do we think of her as a person with a BMI of 38 or a BMI of 32? Now, for me, I think she is a person who's done a tremendous job already at losing weight. I would not penalize her for her success in losing weight. To me, when I think of the treatments she's eligible for, she's a 38-kilogram person. I mean, what are we going to do? Ask her to regain the weight and now she's eligible for other treatments? That's not how I think about her. But again, you have to decide in your own clinical life what to do. So what shall we do? And when I see somebody like this, my typical language is to say, I'm sorry this is so frustrating for you. You know what? I think you're doing a tremendous job already. Imagine how much weight you've lost. Many of my patients talk about this but never do anything. So you've already done a lot. I think you're great. You could accept your weight where it is. And the person usually says, are you kidding me? I cannot live like this. I said, well, you could do more with your diet and exercise, and we could talk about that. And she says, I'm doing a lot. I can't do any more. I said, we could talk about medications. She says, aren't those things dangerous? And I said, or we could talk about surgery. And she said, now that's way too radical. And then I say, oh, I'm sorry, but those are the only choices I have. My purpose here is to help you make some decisions. I frankly think you're doing a terrific job with what you're already doing. Sounds like you would like to do more. Sounds like you're not happy with where your weight is. These are the choices. What would you like to talk about? More diet and exercise, medications, or surgery? So unlike many health problems, I feel like this person is going to have to make some decisions, and they're hard decisions. And so I tend to not be proscriptive about what I'm not saying it, like I do in some conditions, I think you need this medicine. I'm using, whenever I want to push out advice, I try to turn that into a question. Can I take my advice and turn it into a question for this person? Because these treatments that we've talked about, they go from low effectiveness. That's why she doesn't like this. It's not going to give her much weight loss. This is going to give the most weight loss. Surgery is the most effective treatment we have, and it's durable, and I'll show you that data. But time, cost, and risk. It's the easiest thing to do is keep doing what she's doing. The hardest thing to do is to consider something that is pretty major, like surgery. So the choice is for her to decide how much weight loss, how much risk. We have some guidance here from guidelines that suggest we should risk stratify people based on their weight and their presence of comorbid illness. Talking about diet and physical activity, that's appropriate for everybody of all weights and is really the foundation of the treatment. Pharmacotherapy, that is weight loss medicines, are appropriate for people with a BMI over 30 and no health problems, or a BMI over 27 with a weight-related comorbidity like diabetes, degenerative arthritis, sleep apnea, something like that. Surgery is indicated for people with a BMI over 40 or a BMI over 35 with a weight-related comorbidity, especially diabetes. Weight loss surgery seems to have dramatic effects on glucose control. So think of Our Lady. Her BMI was 38, and she has type 2 diabetes that's not well controlled. So in my mind, she's eligible for all of these options. So what are we going to talk about in the few minutes we have? Well, actually, there are more options than that, and I'll just briefly say that when we say diet and exercise, there's a range of those things. She could just monitor her intake more rigorously. She could do simple things like cutting out sodas if that's what's in her diet. She could use a popular diet book. That's going to give her some weight loss on the order of 2 or 3%. She could go to a more formal program with accountability and social support. That's what you get with a formal program like Weight Watchers that you don't get with this, is that accountability. Somebody's watching you, you're weighing in, you're with a group. There are other groups like the Diabetes Prevention Program type groups. These are evidence-based, have been shown to prevent the development of diabetes, and again are structured and are led by trained individuals. We could use medications that give weight loss in this 5 to 10% range, and I'll give you some more data about that in a bit. There are more intensive lifestyle programs run by registered dietitians with more frequent contact. They demand more of the consumer and give more weight loss. You could combine an intensive lifestyle program with medications, and now we're getting up into this kind of 12 to 15% weight loss. There's meal replacement programs where the person stops eating regular food and eats portion-controlled, calorie-controlled meals. Those kinds of programs are particularly useful if your person's losing weight for a target. I need a hip operation. I need to lose this much weight by this date, or something like that. There are questions about sustainability, although we do have long-term data on some of these programs, and they give more weight loss than the standard kind of a diet program. There are now some endoscopic procedures that can be done, balloons, the Aspire device, vagal blockade. These are intermediate between diet and exercise and the surgical procedures, giving on the order of 15% weight loss. There's sleeve gastrectomy and gastric bypass that give on the order of 25 to 30% weight loss, with gastric bypass being a little bit more effective than sleeve gastrectomy. I'll show you some data about that in a bit. And you could combine a surgical procedure with medications or do a more aggressive procedure like the biliopancreatic diversion, and that gives in excess of 30% weight loss. So really the challenge for our patient is, really, you want to do a biliopancreatic diversion? There's a lot of vitamin deficiencies there, but it's going to give huge weight loss. So there's this balance between how much weight loss do you want, how much risk, cost, and disruption do you want? And my task is to try to know enough about these different tools to help the person decide what they want to do or get them to somebody who can tell them more about one of these tools. Let's talk briefly about diet, pharmacotherapy, and surgery. The gold standard for these programs is this diabetes prevention program type diet, or the look ahead like programs. These were NIH funded studies. This one was designed to show that weight loss prevented diabetes. And this is where this study had 4,000 people and showed that 6% weight loss, of which only 4% was maintained for 4 years. 4% weight loss. That's a 200-pound person who loses 8 pounds. I mean, that's not very much weight loss, but that reduced diabetes risk by 60% and was more effective than metformin was. So that's where this idea that modest weight loss is effective came from the Diabetes Prevention Project program. I mean, I think what it tells us is you don't have to lose a lot of weight to have some health benefits. All you got to do is get out of positive energy balance. Most of us, I think, every day are eating more than we're burning. That's why we're gradually gaining weight, is we're just a little bit every day. All you got to do is turn that around so that you're eating a little bit less than you were eating, and that will have some metabolic benefits. The Look Ahead program, that was designed to say weight loss makes you live longer. And that study took people with diabetes, had them lose weight, and the outcomes were cardiovascular disease. What were these programs? They included a 16-week weekly group sessions for 4 months. And they're delivered typically in groups. There's a core curriculum. It's available. You guys, I think, have one of these programs here. Groups are run by a trained behavioral professional, so the physician or care provider doesn't have to do it themselves. These people know what they're doing. The diets are typically a fat-gram budget. So this, as studied, was a low-fat diet. Now, that doesn't mean low-fat diet is the only diet that works, but that is the diet, calorie-restricted, low-fat. That's what was used in the DPP and the Look Ahead trial. The goal was a 7% weight loss through 500 calorie caloric restriction per day and physical activity on the order of 30 minutes a day, 5 days a week. That's what we're all supposed to be doing, right? Meal replacements were an option. Calorie-controlled meals were an option that were used in that Look Ahead trial. So that is sort of the U.S. Preventive Services Task Force says this is the recommended approach to diet. And again, you all have a DPP program here. What do you get with that? These are people with diabetes that were in that Look Ahead trial, about an 8% initial weight loss. They regained, like we always see, so it was only about a 5% weight loss at year 4. So by year 4, it's only about a 5% weight loss. So that's the kind of weight loss they had. Now, are there health benefits to that? The Look Ahead trial was supposed to show that you lose weight and you don't die. The reality was the primary analysis did not show a cardiovascular benefit. It was a negative study. Oh my gosh, does that mean we shouldn't be advising people to lose weight? The study was negative. Well, these are hard studies to do because you have to follow people long enough so that the people who lost weight don't die and the other people do die. Well, somebody's got to die to see a difference. The study was powered for a cardiovascular event rate of 3% per year. When the study started, we thought that people with diabetes have a cardiovascular risk equivalent, meaning just having diabetes is almost the same as having had a heart attack. But in the study, at 3 years, the event rate was only 0.7%. So the study was underpowered. Nobody was dying, so you couldn't show any benefit to the weight loss. Well, what does that mean? Does that mean we shouldn't be telling people to lose weight? To me, what it says is, who was in this study? These are people with type 2 diabetes who take their medicines, are on a statin, their blood pressure is great, they go on all their medical visits, and so I think weight loss is not, it doesn't have a big bang for the buck in those people, it seems like. It seems like Usual Care was doing pretty good at preventing cardiovascular disease. But how about people who lost more weight? This paper in The Lancet is a retrospective analysis. It's not a primary analysis. And they selected out those who lost 10% of their body weight. Remember, the group on average lost 8%. But take the people who lost more weight, and the answer was amongst those people, there was a statistically significant reduction in cardiovascular disease. So one way of interpreting this study is that weight loss doesn't add much to Usual Care if the person follows all that care. Another way of looking at this is it takes more weight loss to actually prevent cardiovascular disease. So 5% weight loss can help your glucose, it can help your triglycerides, it can help your blood pressure, it may put you on less medicine, but it may not reduce your risk of heart disease. 10% weight loss, now we're starting to talk about enough weight loss to have more substantial health benefits. How about pharmacotherapy? Again, I could talk for an hour on this. I'm sorry that I'm not going to. My purpose here is to give you some simple language you can use in the office. If what the person says is, I'm doing as much as I can with diet, I say, what do you think about weight loss medicines? They say, I don't know anything about it. This is my kind of couple minutes that I say at that point. First thing I ask myself is, are they eligible? Because if they're not eligible, I don't even have to have this conversation. BMI greater than 30 or 27 to 30 with a weight-related comorbidity. Who's our lady? BMI 38. So she's eligible. So now I can say the following. The first thing I say is, yes, you can get some weight loss with medications, more than you can with diet alone. It's on the order of 5 to 10%. I usually give the person a number. Say you weigh 200 pounds, we're talking, something like 15 or 20 pounds. You might lose that over 3 months. But it's highly variable. I say some people lose a lot of weight, some people don't lose anything. What you could do, Mrs. Jones, is try it, see if you have side effects, see if you lose weight, see if you find it helpful, and then decide to continue or not. Because if the medication works, and what I think, Mrs. Jones, is a 5% weight loss means it's working. And to me, Mrs. Jones, that's real weight loss. You may not think that's a lot of weight loss, but I think it has health benefits. And what are you going to do? Accept your weight where it is? 5% weight loss. A or B, which do you want? So 5% weight loss at 3 months, then you will probably need to take the medicines chronically. And what I say is, if you take a blood pressure, I think of weight loss medicines like blood pressure medicines. If a person takes a blood pressure medicine, their blood pressure goes down and it stays there. It doesn't keep going down. It goes a little bit and stays, and then you stop your blood pressure medicine and the blood pressure goes back where it was before. I say these medicines are like that. Your weight goes down a little bit, stays there. That's the effect of the medicine. You stop the medicine, the weight's going to tend to go back up. People say, really, I got to take this forever? I said, well, that's the biology. It's a biologic process. These medicines are typically not paid for by insurance, so cost is an important factor, and I say these medicines cost between $20 a month, couple $100 a month. Are we still talking? So what I'm doing here with these 3 questions is giving what I have found to be the deal breakers for people. Some people just think, if I can just get one of these weight loss medicines, the problem's going to be solved. I wish that were true, but we just, for weight loss medicines, we're kind of like where we were with blood pressure medicines in 1960. We got a few medicines and they work modestly. They're not terrific. So I'm just trying to describe the kind of weight loss, the need for chronic therapy, and the money, because some people say, oh, well, if that's what it is, maybe I'll go back to Weight Watchers. So I'm not pushing medicines. I'm trying to give a brief synopsis of pros and cons. Here's some of the data to support some of what I've said here. This is an older medicine, sibutramine, but it's an interesting trial because it's randomized. Drug alone. This is Dan writing a prescription and doing nothing else. You get 5% weight loss. Dan writes a prescription and does some brief counseling. You get a little more weight loss, 8%. Dan sends you to an intensive lifestyle program and gives pharmacotherapy, talking 12% weight loss. So what it shows is the more the person does, the more weight loss they're going to get. These therapies are additive. This is data on variability of response. It happens to be one of these drugs, naltrexone bupropion, and we typically look at these average weight losses, or sometimes categorical weight losses. What fraction of people lose 10% of their weight, or 5%? But here's individual weight loss. Look at that. Some of the people on the medication gained weight. Well, that was not a helpful medicine for them. But some of these people lost 30% of their weight. That's surgical weight loss. So tremendous variability. That's why I encourage people, if they're open to this, try it for a while. It's not irrevocable. If it works, great. If it doesn't, we can try something else. Here's the data on stopping therapy. This is a orlistat, one of these weight loss medicines. Here's a placebo group that just gets diet alone. Here's the group that gets diet plus medicine. That's the medicine effect. So 10% weight loss, that's pretty good. Now that people stop the medicine, what's happened? Their weight goes up. It's a homeostatic regulated system. Here's people who are on diet alone. They add the medicine. What happens? They go to the other group. So this shows that unless you continue the medicine, the weight loss does not persist. There is intermittent therapy. I think some people take a medicine and then they stop it for a while. What happens? They gradually regain. The difference between blood pressure medicines and these medicines is it takes months to lose the weight. It takes months to regain the weight. Blood pressure medicine, blood pressure comes up in a day or two. So some people will take these medicines for a while, stop them, take them again. Some people use them like you'd use an albuterol inhaler in allergy season. If there are times when the environment is going to be more prone to promoting weight gain, use the medicine for a period of time. Because some people are reluctant to use these medicines long term. But their biologic effect is exactly what you would think it is based on their mechanisms of action. So here are some other things we should consider. Here's our lady, we're going to talk about medicines. But think of those other medicines she's taking. Are we promoting weight gain with the medicines we're prescribing? This comes from the Endocrine Society guidelines on weight loss medications, and it's an extensive table. What it shows are different categories of drugs and what the drugs are that cause weight gain and some alternatives that you could prescribe. Again, I won't go through it. The table is actually much larger than this, but if you're a clinician, I think, who's interested in this, this is a useful table to have around. She's on paroxetine for her depression. Bupropion, as an example, is another antidepressant that actually promotes weight loss. I don't personally change people's psych medicines if they're under the care of a psychiatrist, but I may highlight to them the psychiatrist may not have a scale in the office and may not realize that the medication is causing weight gain. So my job is to say, talk to your psychiatrist, maybe bupropion is an alternative. Gabapentin, that's being used for her nerve problems. There are alternatives like topiramate and zonisamide that actually promote weight loss. So before I talk about weight loss medicines, I talk about the current pharmacotherapy and try to optimize for weight losing alternatives. Her diabetes medicines, she could be on a GLP-1 agonist, an SGLT2 drug. So we could clean up her pharmacotherapy initially. Here are the weight loss medicines we have: phentermine resin, diethylpropion, orlistat, lorcaserin, phentermine topiramate, naltrexone, bupropion, and liraglutide. Again, I could spend an hour talking to you about these. I'm sorry that I'm not going to do that. Again, this Endocrine Society guidelines gives a lot of good information about them. These medications, so if somebody says, yes, I'm interested in this, what I tend to say is, some of these are the least expensive. Can you afford $200 a month or $150 a month? If the answer is out of the question, say one of these is $20 a month, can you afford that? And then I only talk about this drug. If people have finances to try these other medicines, I say, what's most important to you? Is it safety, side effects, or effectiveness? Of these, the phentermine topiramate combination is the most effective, produces the most weight loss. Lorcaserin is not as effective, but it has very few side effects. Orlistat is the safest. In fact, this one is available over the counter, but it has some side effects. So, and then naltrexone, bupropion, liraglutide, 3 milligrams. These are intermediate in effectiveness and side effects. So I try to tailor my conversation. I know more than that about these medicines. I try to highlight the key feature. We have some materials in the office that we can give to people. They can read about it at home and call me back in a week or two when they decide what to do. Obviously, there are side effects to these medications, and again, I won't go over these in detail. Orlistat blocks fat absorption, and so it has GI side effects. Lorcaserin has the fewest side effects, and they're fairly modest. Liraglutide, nausea is a big problem. Anything with phentermine in it can raise blood pressure and heart rate, and so we don't use those in people with active cardiovascular disease or uncontrolled hypertension. There are contraindications, and again, I'm sorry that I'm not going to go over all these. You maybe have access to these slides if you want to, or that Endocrine Society guideline. Key thing here is pregnancy. If a woman's going to be on these medicine and is of reproductive age, I think we have to talk about contraception, especially with this phentermine topiramate, because topiramate has clearly been shown to cause birth defects. This is a meta-analysis. We don't have head-to-head comparisons, so where do I get off saying this drug's more effective than that one? We don't have head-to-head comparisons. But this is a meta-analysis that compares the studies we have, and what it is looking at here is what's the chance of getting side effects. So the higher up here, the fewer side effects, and how about weight loss? The farther over here you are, the more weight loss you get. So what you can see is placebo doesn't give much weight loss. It doesn't have a lot of side effects. Lorcaserin has the fewest side effects, but has only modest weight loss, as opposed to phentermine topiramate, which gives the most weight loss but has moderate side effects. So that's where the data comes from for the conclusions that I was making there. Well, the reality is we're not prescribing these medicines. This is data from U.S. pharmacy data. 70% of all prescriptions is what kind of data is looked at here. He's people with type 2 diabetes. The red is how many people in the population are eligible. So about 8% of the U.S. population has type 2 diabetes, and almost 85–90% of them are taking a medicine. Here's obesity. 40% of the population is eligible for weight loss medicine, and 1.8% are getting one. What is the story here? Why is nobody using pharmacotherapy? And you look at the trends here. This is phentermine prescriptions. These are the new weight loss medicines, and this is SGLT2 inhibitors. This is the new diabetes drug. As soon as those drugs came out, providers, primary care doctors, and endocrinologists jumped on the bandwagon and gave those medicines. Nobody's giving these medicines. Why is that? Well, I think people are legitimately concerned about safety issues, although that didn't stop us from prescribing SGLT2 inhibitors. We jumped on that bandwagon. And these drugs are FDA approved, and we have long-term safety and efficacy data for all of them except phentermine. There are efficacy concerns. Maybe 5-10% weight loss is not enough for our patients. I understand that, but it's accept your weight where it is or 5% weight loss. Which would you choose? There's not payment. I think this is a big issue. Some of these medications are, $200-300. I mean, liraglutide is many hundreds of dollars a month if the insurance doesn't cover it. So payment, I think, is a big issue. The provider issues, this is a long conversation, and you have to practice it to get efficient to do this in a quick period of time. So that's a problem too. But I think our own attitudes about weight are involved here as well. This is a quote from the New England Journal from 2016 by a prominent primary care doctor. New England Journal, promoting and prescribing drugs to treat obesity does a disservice to our patients, society, and ourselves. Such prescriptions may help patients lose a few pounds in the short run, but these drugs violate nearly every principle of careful conservative prescribing. Oh my God, this guy's like way down on this. These are FDA-approved drugs. Where's this thinking coming from? Well, there are experimental studies looking at what goes in our heads when we see somebody who struggles with their weight. These studies show that physicians see patients with obesity as being less compliant, having less self-discipline, and being more annoying. In fact, providers report feeling that caring for obese patients is a waste of their time. This is a review of this. So this is weight bias. In this is deeply embedded. I mean, I do this for a living, and I'm guilty of this. I'm in the grocery store. I see somebody who struggles with weight. I look at their grocery cart. What business do I have looking at their grocery cart? Like, who am I, the nutrition police or something? I don't know anything about that person. We don't do that with other diseases. You see somebody with diabetes, you don't go, what's the matter with you, But I think there's just this embedded thing that I encourage us to be aware of. And that's why I spend so much time on the biology. This is a biologic process. Nobody chooses to struggle with their weight. And so I think we have to sort of be at least aware of our bias to start to have that conversation. I've taken too much time, so I'm going to go fast here. I'm sorry. I understand there's even surgeons in the room. Damn it, you're so nice to come. Oh, my gosh. So surgery is the most effective treatment we have. There, I said it. There's sleeve gastrectomy, gastric bypass. Nobody does these lap bands anymore. Yes, they had low risk in the short run and higher risk with this gastric bypass and higher effectiveness as well. So the lap band had problems in the long run. It's a mechanical device, and it can have mechanical failures after years. So these are the two operations that are the most commonly done. And this shows that. This is how many people had sleeve gastrectomies in 2010 to 2013. So sleeve gastrectomy has gone up over time, and gastric bypass was starting to go down. Now, across the country, there are way more sleeves being done than gastric bypasses being done. People say that surgery doesn't work. This is data from the Swedish obese subject study. It's a very old study, but what it has is these are gastric bypasses. This is the weight loss at 1 year and 20 years. This is 20-year data on gastric bypass that shows great initial weight loss, some weight regain over the subsequent years, but 25% weight loss compared to controls at 20 years. So yes, the surgery fails in 5 or 10% of people, but in a majority of patients, it produces durable weight loss. And that durable weight loss probably has health benefits. This is an observational study of 2,500 surgical patients compared to 7,000 controls through the VA. If you have surgery, that's the yellow line, you are more likely to die in the first 6 months. That's surgical risk. But by 2 years, your mortality rate is lower than controls, and it's about a 25-30% reduction. So surgery, we don't have a randomized controlled trial, but it probably reduces mortality. Interestingly, these people, what are they not dying of? They're not dying of cancer as well as cardiovascular disease. We know that excess weight promotes cancer, but this kind of data suggests that weight loss may prevent cancer over the long run. Last piece of data here, benefits of bariatric surgery in people with type 2 diabetes. This is a randomized controlled trial, and what they do is they say, if you have type 2 diabetes that's not under great control, that's our patient, right? You could go see Dan, or you could have a bypass operation or a sleeve gastrectomy. At 1 year after those procedures, or seeing me for a year, what's the chance you're going to have an A1C less than 6 on no medicines? Nobody who sees me is that. Of the people who have a bypass, 42% have an A1C less than 6 on no medicines, and 27% of people who have a sleeve gastrectomy have that. Oh my gosh, that is dramatic therapy. How about by 5 years? If we do the same thing at 5 years, still nobody has an A1C less than 6 who are seeing me on no medicines. It's now down to 22%. So the effect is waning. The benefits on glucose therapy don't persist, but still 22% on no medicines with an A1C less than 6. Sleeve gastrectomy doesn't perform quite as well as gastric bypass in this regard. But if you take a more modest endpoint, like an A1C less than 7, that's 50% of the bypass patients and 49% of the sleeve patients. So weight loss surgery is the most effective treatment we have for weight. It's also the most effective treatment we have for type 2 diabetes. And here's a more granular look at that. People who are seeing Dan, oral medicines, insulin, many of these patients are on a bunch of medicines. The people who have had gastric bypass have better glucoses, and many of them are on no medicine, and fewer are on insulin. So it simplifies people's life. Yes, there's risks to this, though. You might die from the surgery. Although the current death rate amongst centers of excellence when things are done laparoscopically is 0.1%. That's the 30-day death rate from bariatric surgery. And that's comparable, really. It's actually less than a lap chole. It's better than a hip replacement. So yes, this is life-changing, big-time surgery, but it's not like having your heart operated on or even having a hip replacement. The surgery does occasionally fail to produce weight loss or there's weight regain, but that's a minority of patients. There's a lot of vitamin deficiencies that are at risk for after a bypass, less so with a sleeve, although still those folks need monitoring as well. So this is not without risk. And I'll stop there. So, sorry to go on so long. I was talking fast there, wasn't I? Yeah, but that's okay. You're smart, and I'm trying to keep you awake too. So, the main thing I want to give you is body weight is regulated by powerful biologic processes. This is like treating hypertension or stuff. This is a biologic thing. People don't choose to weigh what they weigh. There are a range of options. They're not as great as we would like, but these are things I feel like we should be comfortable talking to our patients about. I'm not saying everybody needs to be on a weight loss medicine or that everybody needs to have surgery, but I think when somebody comes to our office and says, I hate my weight, I think you should feel comfortable having an empathic, informed conversation with them that they find useful. Take care. Yes. Yeah, so the question related to therapeutics, I'm going to paraphrase, therapeutics that came from this basic science knowledge that have impact. What's been amazing is all this biology in the hypothalamus, amazing neuroscience, the therapeutics that come out of there have not been helpful. People thought leptin, no, that's going to cure obesity. It didn't. The NPY-related drugs have not worked. What I take that to mean is we're not eating out of hunger. The hypothalamus is hypothalamic feeding. I think we're eating out of other reasons. But I think probably combination therapy is where we're ultimately going to go, where we're using several drugs. I mean, think of hypertension. If all you had was one drug, you couldn't treat hypertension. You give somebody a potent vasodilator, they get sodium retention and adrenergic activation. It's by having multiple drugs that act in different ways, that's how we get good blood pressure control. We just don't have a conceptual framework for that in weight. So I think we still have some ways to go. Yes, sir.
One of the best lectures I have heard, if not the best, on obesity, and my aim is high.
Thank you, sir.
Yeah, I am trying to understand why is it if the system of obesity is regulated, as you indicated. After surgery, there is the persistent weight loss. Is there a change beyond the anatomy that happens in the regulation of weight?
Great. Yeah, so the question was, if this is such an entrained biological system, how does surgery work? Because we used to think surgery enforced the diet. That's definitely not what happens. If you talk to somebody who's had surgery, you should do this. My favorite question is to say, so what'd you eat yesterday? They say, oh, I had a couple of tablespoons of oatmeal and 4 ounces of a protein shake. And I'm like, God, that sounds horrible. I don't say that. It says, so I said, what'd you eat before your surgery? And the person, these are the same people who told me I'm eating nothing and can't gain weight. And I say, what'd you eat before surgery? And they go, almost to a person, they go, oh my God, I can't believe how much I ate before surgery. And I say, well, so why aren't you eating that? And they say, well, I'm just not hungry anymore. Some of them will say something like, I've never felt full in my life until I had surgery, and all of a sudden I'm full. So the surgery does not enforce diet. It's some kind of neural humoral therapy. Now, the initial data suggests that ghrelin levels go down, and that was the cause of this. That's been a little bit controversial. Some of the most exciting work has been in transgenic mice. They do gastric bypass in mice. Oh my God, that's a tiny little operation. But they've done like ghrelin receptor knockout mice, and they still lose weight. So that's powerful evidence that ghrelin is not the mediator of the weight loss. So then the hardcore scientists have looked more broadly and in an unbiased way. What changes before and after surgery? And the couple things that are sort of high on their list now, one are bile acids. Who would thunk? So there are bile acids in your bloodstream, and this surgery changes the uptake of bile acids into the circulation. And so they've done bile acid receptor knockouts, and those animals surgery does not work in. So that's pretty powerful evidence that it may be circulating bile acids is the mechanism. There's a bunch of stuff on microbiome and things like that. Suffice it to say, it's not something simple like the stomach is smaller so I'm full. That's not the answer. It's some complex interaction with the regulatory system, but we don't completely understand it yet. Great question. Yeah?
I just wanted to recommend a book that really complements this talk, which is called Health at Every Size. And her last name adds to her credibility, I think, Dr. Linda Bacon. But it's a really awesome book for looking at weight isn't always the answer.
Yeah.
It's about health behavior and destigmatizing weight. So highly recommend it. It's very readable and great.
Say again, Health at Any Weight.
Health at Every Size.
By Health at Every Size, and the author is?
Linda Bacon.
Linda Bacon. You can't forget that name. Yeah, again, I think people are worried about their weight. And so when somebody asks me about the weight, I try to respond to that concern. But I think you're exactly right. I think eating a healthful diet, being physically active, has benefits beyond the weight. People who are fit and overweight have lower mortality than people who are lean and unfit. So again, I talk about what the person wants because I feel like that's my job. But I think what I'm trying to do is to keep the thing positive. There's just so much negative feelings about this, so I try to empathize with the person as best I can. Yes, sir.
In the old days, people had cancer of the stomach, and they oftentimes would end up with dumping syndrome. Have any of these people been studied as far as their metabolism is concerned?
Yeah, so the question related to cancer of the stomach, probably resection, surgical things, and then people get dumping. And how does that relate to this? Did I get the question right? Yeah, so I think there's a couple parts of that. What is dumping? And there's some different ideas about that. How I think of dumping is that a lot of undigested nutrient gets into the distal bowel, pulls in a lot of water, and people have vagal symptoms and watery diarrhea. That actually doesn't happen super commonly here because people tend to avoid those foods because they don't feel well. What people can get here is post-bypass hypoglycemia has become a big problem here. That's maybe a 3 to 7% item. These are folks, probably one of the other things the surgery does is increases GLP-1 secretion and increases insulin response after the meal. That's probably why the glucoses get better. Over time, people probably get beta cell hyperplasia and hyperinsulinemia that can actually cause frank hypoglycemic after they eat. That's not dumping, but it's symptoms after a person eats, and that has some special dietary and even potentially pharmacotherapy management. But dumping has not been a big problem with this operation. Did that sort of answer the question? Great. Yes? Gastric balloons was the question. Yeah, these new endoscopic therapies. I must say we had a round of balloons maybe 15 years ago, and they caused lots of problems, obstruction and things like that. Now there are 3 different manufacturers that make these balloons, and initial data looked actually pretty promising. Like you can't keep that in forever though, right? So it's really they're approved for 6 months of use, and then people take them out and they can do another round of it. the treatments only work as long as you do it. So I think I keep that in mind. They have new ones that are, you don't even need endoscopy. The balloon goes, you just swallow it. It's got a little tube. They make sure where it is by a radiograph, and then they can inflate it that way. So it's simple, can be put in an office. So I think the jury is still out a little bit. They're FDA approved, so this is not experimental. This stuff is available. Do you guys have anybody here that does these? Yeah, well, we do at our center, and that person is quite good and quite attentive, really focused on diet and things like that. So I think it might be a growing part of this. Yes, sir.
Well, I've been hesitant to ask the question, but I'd love to hear your opinion on the culture of food. I mean, you go to Italy, there's plenty of food. The country, for the most part, people are not starving to death. And yet you don't see BMIs of 30 or 40 in every street corner as we do in the United States. So how do you respond to that observation?
And I had a great dinner with you last night, too. Man, it was so good. And the dessert especially. Yeah, no. So the question had to do with culture of food, which really relates more broadly to why is there more weight problems in some places than others? Is it physical activity? Is it the kind of food that people are eating? Is it the way food, the meaning of food culturally? Or is it something else? Is it the ambient temperature or the altitude? I mean, Colorado, I come from Colorado, it's the leanest state in the country. People say, oh, it's your altitude. Like, what does that mean? Like I breathe harder or something like that? So I think you're right. I think there are lessons to be learned about different places. Is it all culture of food? I think actually it's probably many of these different variables, and it's hard to sort out. And that's the hard part. Like, what am I going to do? Move to Italy where the culture is different? Can we change the food culture here? Why is our food culture like it is? I hear a lot of people say, oh, it's the industry. They're selling us a lot of junk. I told some folks last night, I met with some of those people. I was giving this talk to $8 billion worth of food industry people. I'm like, I'm going to stick it to them. And they're just like, no, we just give you people what you want. You know, if we give you healthy options, you don't buy them. And we're in a business here. So it's a very challenging thing. How do we as providers change our environment and our culture? You know, I think we can talk about being physically active. We can each eat a healthful diet ourselves or try to do that, but not go crazy. I don't know. Yes, sir.
Factors in pregnancy that can affect obesity and progeny.
Wow, great question. Pregnancy and progeny. I mean, I had somebody ask yesterday, well, how about kids? How does kids affect their weight later? What you're raising is in utero environment. And so what we know is babies born to women who have diabetes, gestational diabetes, they're bigger and they have more obesity. We also know that infants born to women who are malnourished, Idaho potato famine, those kids are bigger. So there's something both with over and underfeeding of the mom. People have been looking at mediators. Is it glucose? That was the old idea. There's actually new data that's actually mother's triglycerides influence baby's body weight. And how does it do this? And what we now know is, again, everybody knows the genome and DNA, but what your genes actually do is related to epigenetics, the way the DNA is modified with histones and other modifications that in utero environment can do. It's very clear that in even non-human primate studies, the uterine environment is very relevant to long-term weight gain. But how do you do a study on that? You know, what's a healthful diet for the mom? And to know you'd have to see the kids 40 years later. That's a hard study to do. Yes, sir.
I understand that the hemostatic process makes it difficult to lose weight. All these other factors kick in. Why does that allow us to gain weight, though? It seems like that should be working against us to be gaining weight.
Yeah, great question. So what you'd think a homeostatic regulatory system should both prevent gain and loss. And I think what we observe is that in this environment, the system regulates towards progressive weight gain. My answer to that would be, I think this biologic system evolved in a very different environment. Again, if you lived in Portland here, 300 years ago, and you woke up this morning, where am I going to get my coffee from? What am I going to eat for breakfast? It would have required a high level of motivation to do dangerous things to acquire nutrients. And so that sort of just regulatory system in this environment is inappropriate. So I think that's the best answer I could give to that. Yes, sir. Last question of those, yeah.
Receptors for satiety or hunger. Any recent information about
Yeah, so again, I think the question related to receptors for satiety and predisposition to weight gain in those people, maybe genetic variability. Again, I think the therapeutics suggest that the hypothalamic regulation may not be central, but you ask also about genetics. So are there genetic markers that relate to weight gain? Are they in receptors and things like that? And there are a couple of well, it's very polygenic. Many genes are involved. They each have very small effects. Many of them have nothing to do with appetite, but have to do with metabolism. A couple of them do relate to appetite. The melanocortin-4 receptor is a genetic abnormality present in about 2% of folks that may be related to weight gain. No firm answers from genetics about mechanism. And I'll stay and answer questions if anyone wants to say. Thanks so much for letting me visit you.